and get started. So again, I'm Christina Ching. Oh, I think it does this funny, because now I think you see this weird screen. I may just leave it. I apologize. I may just leave it in this form. I don't know how on when I share my screens to make it not do that thing. So I apologize. It's not going to be in a slideshow, but so I'm Christina Ching. I'm one of the pediatric urologists at Nationwide Children's Hospital, which is a children's hospital in Columbus, Ohio. So I don't know how familiar some of you are with where Columbus and even where Ohio is. So I just put this map that shows Ohio. We call it the Midwest, but really we're not. We're more like the Mideast. We're not really in the West, but this area of the country is called sort of the Midwest, if you can see my pointer. And so my state is Ohio here. And gosh, my computer is going to restart, but I think we will be okay for this presentation. But so my state is Ohio, and then I live in the city that's the capital of Ohio and noted by this red star. This is just a picture. We have a river that runs through our city. This is a picture at night. It is a particularly nice picture of our city. But we are the largest city in Ohio. This is my hospital, Nationwide Children's Hospital. It's not a new hospital per se, but this building, our inpatient building actually was renovated, I want to say maybe in 2013. So it is newer and it is very nice. We are affiliated with the Ohio State University, which is a very large public university that is known for its American football team, as you'll sort of see down here. They are usually a very good and strong team. But Ohio is quite lovely with a lot of parks. You can see this is a particularly famous one with many waterfalls called Hocking Hills. And then it is an urban, it is a city. So I have been part of IVU. Actually, I started in residency and I've been in attending since 2014, but I think my first trip was maybe in 2010. And then I have been, since being staff, I've been on 1 to 2 trips a year. This happened to be, I believe these pictures are from Ghana. I have not been to Uganda yet, but I would love to come to Uganda. I've been to Ghana, Zambia, Mozambique, and Senegal. So just looking at normal bladder function, if we look at the definition in Campbell's, which, we kind of consider our main textbook of urology, that the goals of bladder function are to store a socially adequate volume of urine. So there's that social dynamic of obviously continence, but then also without a significant rise in pressure and thus be highly compliant. So there's also then the safety consideration of protecting the kidneys for normal bladder function. So when we look at mechanisms of continence, there's the importance of the bladder and the importance of the outlet. So the bladder and outlet work in actually opposites of each other, but they do require the synchronous activation of smooth muscle between the bladder and the outlet. So when the bladder is filling, you need the bladder muscle to be relaxed and you need the sphincteric mechanism to be closed. But then when it's time to empty at a socially appropriate time, you need the bladder to squeeze in a coordinated manner, and actually you need relaxation of the outlet. So really the bladder serves sort of a dual function of storing, where it's very compliant. So the pressures are low in the bladder for storage, and you need that closed outlet. And then when you void, you need that contraction, that coordinated contraction and opening of the outlet. And when you have abnormal bladder function, where sort of there's that discoordination between the two, or one is not functioning, you can have social consequences with incontinence. And then, kind of from a health and safety aspect, you can have renal injury and get infections. The neurologic control of the bladder is through the sympathetic nerves for storage, through the hypogastric plexus. For voiding, it's a parasympathetic response through the pelvic nerves. And for the coordination or contraction of the external sphincter, you need the somatic nervous system, which is through the pudendal nerve. And we know that with various neurologic insults, you can make some generalizations of what you're going to expect with the detrusor, the internal sphincter, and the external sphincter. And so you can sort of find these different, charts that will go through whatever the neurologic disorder is, whether it's myelomeningocele spina bifida, if it's a spinal cord injury, and depending on where the level of the injury, you can have these sort of expectations of what you'll find. But I will say that these are also variable, and it's not necessarily always so obvious or so cut and dry about what you're going to find. And that's where urodynamics play an important part in helping manage patients with these abnormalities. So in the evaluation of the bladder and the outlet, urodynamics can tell us something about bladder pressure. It can actually also tell us something about urethral pressure. It can tell us things about the bladder compliance, as well as bladder overactivity. And then you can add the video component to urodynamics, which is really basically performing a VCUG at the time of doing the urodynamics, because you're filling the bladder anyway. Why not, instead of filling it with saline, filling it with basically a radiopaque contrast? That allows the visual evaluation of the bladder and outlet, so it can give you some idea of how the bladder appears. You can look for reflux. It can tell you something about the timing and grade of reflux. Is it during filling? Is it early during filling? Late? Is it during voiding? And then you can also evaluate the bladder neck and urethra. There's also an element of just that scout image, that initial X-ray, that can also give you some idea of if there's a sacral anomaly. So maybe you're doing some of this workup because you don't know if the patient has a spinal cord abnormality, but you have sort of the clinical scenario of incontinence or recurrent urinary tract infections, maybe abnormal ultrasound of the kidneys. So that scout image can tell you a little bit about what the sacrum looks like. Do they have a sacrum? You can look at their stool burden to see if maybe constipation or a neurogenic bowel is participating in sort of their clinical picture. And then you can also look for stones in the urinary tract. This is just some example of what a video portion of the urodynamics could show you. So, on this left side, you see a relatively smooth-walled, kind of expectantly normal appearing bladder with a closed bladder neck, versus this bladder, which you're starting to see some trabeculations, maybe even a little diverticula there. And then you see this open bladder neck. If I was to tell you that this is not during voiding, you see that the bladder neck is actually open. So this is not a purposeful opening of the bladder neck to initiate a void. So it's suggesting an incompetent bladder neck. Whereas also you can look and see what does the sphincter do when they are getting ready to void. So here's a normal appearance of the urethra with voiding, versus here you see this dilated posterior urethra, or oftentimes we'll call it, if this is a female, spinning top urethra, looking for either dysynergia of the detrusor in the sphincter, or looking at dysfunctional voiding if you don't have a known neurologic lesion. So urodynamics, what it shows is it's a study that provides measurements of the function of the lower urinary tract. It is a dynamic study of the storage and the evacuation of urine. The components are that you have cystometry, which is looking at the bladder pressures during filling, and then you have the pressure volume relationship during micturition, known as the pressure flow, or oftentimes we'll just call it even a uroflow. Let's think in for a second. So the clinical questions that urodynamics can answer, they can answer questions about the safety of the upper tract, some reasons for incontinence, reasons for urine infections, and then again, if you have concern for a spinal cord abnormality, there's some signs of kind of increasing that concern depending on what you see with urodynamics. So I think I'm missing a slide. There we go. So how urodynamics is done It's done through 2 catheters. So you need a catheter in the rectum to measure abdominal pressure, and you need a catheter in the bladder to measure the pressure in the bladder. Those catheters are connected to transducers, and then the one in the bladder is actually also has usually a dual lumen to allow the installation of your fluid. So it has a peristaltic pump. The transducers are then connected to a computer or machine that will basically read the pressures to generate this tracing. And similarly, you might have a flow meter for the uroflow component that is going to contribute to the tracing that's generated. This happened to be just, I took some pictures of what our urodynamic machine looks like, but these are the 2 transducers, one, in the rectum, one in the bladder. You have your, infusion, your saline infusion that you're going to be then instilling in the bladder. And then sort of the computer is sort of way in the back here that, the transducers are connected to read the pressures. So how to read a tracing. This happens to be our what our tracing looks like. Some tracings may, depending on the machine, may not have an EMG component, but the important pieces are those 2 catheters. The one in the bladder is measuring the bladder pressure, it's the P vesicle. And then the one in the rectum is measuring the abdominal pressure, and that's P abdomen. And what's really important is this reading, which actually is a calculation of subtracting the bladder pressure from the abdominal pressure, because you don't want to just read the bladder pressure, because that can be influenced by, valsalvaing or any sort of abdominal pressure. You're going to see P vesicle rise. So you actually want to subtract the 2 and get P detrusor, which is really the reading that we're most interested in. You can also, if you have the capabilities, you can record sphincteric activity through either EMG pads or needles that we'll talk about a little later. And then you need also to measure the volume infused. And so that's that last measurement to show, again, what saline you're infusing. And then the other really important piece that whoever is performing the urodynamics should be doing is they should be documenting some clinical information at the top of the tracing. So for example, you can see they should mark when the patient maybe has first sensation, if they leak, if they're getting uncomfortable, when they would want to get up and go to the bathroom. And again, also, as I said, what maybe the so you're getting that feedback from the patient, but then also having the information that the person performing the tracing can say, I asked them to cough and increase their abdominal pressure, or I noticed leaking at that time. So these are some of the endpoints that you're looking for during the cystometry on the left side in blue, and then in the uroflow portion on the right side in yellow. We're going to first focus on the left side, the cystometry endpoints here, and go through them one by one. So if we look at bladder capacity, you want to calculate the expected bladder capacity. In pediatrics, we base it on a formula. When they're less than a year of age, we calculate it by weight in kilograms. And then if they're older than 1 year of age, we actually base it on their age to get a milliliter volume. And it's important to calculate that because that will help you decide the rate of your infusion. So you want to do a rate that's 5 to 10% of their estimated bladder capacity with a maximum fill rate of 20 milliliters per minute. You want to make sure the temperature of the fluid is not too cold to potentially create artificially create findings on your urodynamics. When you stop infusion, when the patient has, when they void or they have a strong urge to void, if you see detrusor pressures going over 40 centimeters of water without a void, you can stop. If you fill to 150% of their expected capacity, or the rate of leakage matches the rate of filling, because basically the study then becomes negligible. So now looking at compliance. What you're trying to figure out is if there's normal compliance or if there's abnormal compliance or change in compliance. So normally the detrusor allows bladder filling with little or no change in pressure. And compliance is really this calculation of change in volume over change in pressure. when the starting point is at the pressure at the start of bladder filling, and the end point is when you see that the detrusor pressure, or is the detrusor pressure at capacity or immediately before the start of a contraction that leads to a significant leak or basically to voiding. So this is an example. If we look at this as over time, you have this change in pressure of the detrusor. This is a poorly compliant system. Normally you want the change in pressure to be negligible, so this should be flat. So if we look at what that looks like on a urodynamic tracing, so again, the P-det is really what we want to see. And so you're looking at this is time on the x-axis and pressure on the y. So over time, there's really no change in pressure. So this is a nicely compliant bladder. This is normal. Here we see that over time, you see the pressure starting to rise up until the patient has a leak. This shows that there is a change in compliance. This is not a compliant system because, again, it is not holding volume at a low pressure. The pressure is actually rising. Okay, so now looking at the variable of looking at sort of the detrusor itself. Is it normal, or is it, kind of quiet, or is it overactive? So we define detrusor overactivity as an involuntary contraction during filling that's really greater than 15 centimeters of water from baseline. Although sometimes I will have to say, I don't always hold it strictly to that greater than 15 centimeters of water. But again, kind of looking at this again, overall, there's really no contraction, kind of disregard this little blip, who knows what that was, but there's really a very quiet appearing bladder. This is normal. Whereas here you can see you're generating during filling at low volumes. So say I told you this was a 10-year-old patient. They are filling, I would expect a 10-year-old, their bladder compliance to be about 360. They're at 70 cc's, showing that they are having these strong contractions of their bladder and even generating a leak. So this is bladder overactivity. You can see that happening again here. So again, if I said this was a 10-year-old myelomeningocele patient, you're seeing leakage at very low volumes and really kind of this overactivity throughout. If this was a patient who maybe had been doing okay, but then was having increasing incontinence and we saw this finding, I would reevaluate their spinal cord to look for like a tethering to see if that is what is happening. So that's how you can use urodynamics. This patient already had sort of an abnormal neurologic, finding from their just initial myelomeningocele. But if I'm worried for another insult to their spinal cord, if this was a change in their clinical picture, I got this urodynamics, this overactivity would make me want to reassess their spinal cord. This is an interesting one because, again, we see at low volumes all this overactivity initially, and then even overactivity with leakage. But one thing I wanted to point out about this is not just concerns about overactivity. You also have to see, where does the baseline after the overactive event, where does that return? So this is returning at higher and higher kind of pressures. So I would worry not only about overactivity, but compliance. So this is different than this patient, where they actually had pretty much, maybe a little bit here, but pretty much they had returned back to their baseline. This, you're seeing the kind of, it's a little bit easier to see that as they, with time, as they continue to fill, there's also not just an issue with overactivity, there's an issue with compliance for this patient. Okay, looking at detrusor leak point pressures and Valsalva leak point pressures. So why is a detrusor leak point pressure important? Well, it can tell us about a risk of upper tract damage. What is it? It's the lowest value of the detrusor pressure at which leakage is observed in the absence of a detrusor contraction or increased abdominal pressure. So it's basically the volume, the pressure at which you will see leakage that is without a contraction, or again, related to valsalving and overcoming your sphincter mechanism. And that's important because, again, higher pressures will mean that pressure, instead of almost kind of popping off and leaking, that's the pressure that your upper tracts are seeing and can lead to upper tract damage. So again, if we look at this, and this is where it's very important looking at our kind of our notes, our clinical notes at the top of the study. This patient didn't leak, and they also didn't have a change in pressure. So this is a normal study. This patient, we're looking at the notes made about leakage. We're seeing where they first leak. They're leaking at 39 centimeters of water. And then this is in the absence of, for example, them writing that they, you know, pushed on their belly like they did over here, or that they made the patient cough. And it's in the absence of a detrusor contraction. So this is an actual detrusor leak point pressure, and this is what I would read. And I would be worried about this patient. I would say even that idea of it being okay under 40 and over 40, it's not even that I would, I mean, I'd still be worried at 39. I don't think that I would just specifically say, oh, they're 39, they're not 40 yet, I'm okay. No, this is concerning. Same scenario here. So what was interesting with this one is that the pressures actually, so I don't think they probably weren't leaking enough that they weren't dropping their pressures. Whereas this patient started leaking and then actually the pressures dropped a little bit, which is good. But again, it took up until about a 54 centimeters of water before we saw any sort of leakage. So what's going on here? So also I am giving you some clinical information on the left side. So this is an older patient, 49-year-old female with myelomeningocele. And we see this leakage here. Is this leakage related to, again, just filling? And so this is a kind of a sharp change in compliance. So this is a detrusor leak point pressure. Or is this an actual generated, albeit kind of sustained and kind of, you know, like a sustained bladder contraction? I don't know that I know the answer to that. I would think this looks more like a bladder contraction. So if that's the case, this is not their detrusor leak point pressure, that's 48. That's not their detrusor leak point pressure because it's associated, that pressure in that leakage is associated with an actual bladder contraction. So this is a tough one, and you have these scenarios where it's maybe not so clear. Is it a bladder contraction or is it an actual just rise and change in compliance? And it's just rising pressure that then generated this leak. Abdominal or Valsalva leak point pressure. So this is the lowest value of an intentional increase in intravesical pressure, promoting urinary leakage in the absence of a detrusor contraction. So this is related to tightening, you know, increasing your abdominal pressure, valsalving, coughing, you know, just trying to bear down, and it's really trying to determine the competence of your outlet. So again, some of the examples are to blow on the arm, cough, bear down, have the patient jump around, and you're looking for that leak at greater than 60 centimeters of water, because if it's less, that suggests that their sphincteric mechanism is incompetent or deficient to prevent leakage in just the, you know, due to a rise in abdominal pressure. So what does that look like? And again, this is where it's really important to see what's happening in their clinical kind of notes. So filling the bladder, sorry, that's actually kind of cut off, but you can see down here, they're filling the bladder. And maybe there's a little bit of change in compliance, but when they're asked to Valsalva, they actually leak. And it's at a pretty low pressure. You know, it's only at about 20, maybe 21 centimeters of water. You could even say is it the 10, because who knows what that little blip, but it's less than 60. And this would be where, for example, having the video portion, you would see at the same time that their bladder neck, they're not generating a bladder contraction, but their bladder neck is open and they're starting to leak. Some other pressure measurements would be documenting the maximum pressure during filling and then the end filling pressure. Those measurements are just, you know, for understanding what they are demonstrated here. I don't know how important those are, to be honest, in my clinical decision-making for a patient, but they are some of the endpoints that are and can be recorded in urodynamics. So this is the maximum pressure during the study, just really looking at, and again, I'm not measuring during a contraction or overactivity, I'm looking at that baseline where it returns to. The maximum pressure here is about 21, and that's just sort of eyeballing where, you know, they've measured, or you could maybe even do 22, although is that a little bit and sort of a little bit of some overactivity there. And then just the end filling pressure at the end of the study, what is the filling pressure? Let's talk a little bit about EMG activity and how to measure that. You can either use patch or needle electrodes? Do you guys use one or the other?
No, we're not able to routinely do that.
Yeah, you know, and some of the systems aren't. Some of the machines, this isn't routinely measured. If you're going to measure it, so we actually typically do patch. Patch versus needle, they are different. Obviously, they are what they sound. So patch is a less invasive way of looking at EMG activity. They just literally kind of put patches on the perineum. There are some problems with it in that it obtains a larger, information from a larger group of muscles because it's not specifically in the pelvic floor or in the urinary sphincter. So it can record the anal sphincter, which doesn't always correlate with what's happening with the external urethral sphincter. And it can be subject to artifact because if they do start leaking or if they're voiding and the liquid runs over the patch, it can really, I'll show you actually an example of that. You can't really interpret the EMG reading. Needle is more specific. You can actually try and place it into the external urethral sphincter. They're less likely to get artifact because they aren't affected by, some liquid falling over them. If the patient's really hairy, the patch is sometimes hard to get kind of to stick in that area. So you don't have to, the needle doesn't have that sort of same issue. But in a sensate patient, that's sometimes hard to do. We have a lot of insensate because you're doing it for myelomeningocele or something like that. But we aren't set up to do needle. So we typically do patch. And you're looking for, kind of the activity of the urethral sphincter. So if you have reduced or no EMG activity, this can indicate an incompetent urethral closure mechanism. Whereas if you have a lot of activity and specifically during their detrusor contraction, so when they have been given permission to void or they're voiding, when their, kind of volitional void would be, if you see concurrent contraction of the urethral muscle on the EMG, you worry about if they have a neurologic lesion, detrusor sphincter dysynergia. And if they don't have a neurologic lesion, then it's called dysfunctional voiding. So let's look a little bit at what that looks like. So you have your PDET, the patient has been, again, you need to have the clinical information available to you. They've been given the permission to void. They're starting to try and void. And you see this EMG activity that's sort of intermittently firing, but then it's firing while they're trying to void. And this is maybe what you'd see on your video portion, if you're doing a video portion where they're trying to void and they're fighting their sphincter mechanisms, you get this dilated posterior urethra. But it's important that you know if they're trying to void or not. So here you see this patient with some EMG activity with activity going on in the detrusor. But what if they're not trying to void? What if this is just actual bladder overactivity? Then we actually call this guarding. So their sphincter mechanism is actually trying to appropriately keep them from leaking. So it knows that the bladder is inappropriately contracting, and actually the sphincter is firing to try and prevent leakage. So that's not necessarily an abnormal response. So it is important, again, I can't overemphasize using what is happening clinically during the test up on top to understand what is, or being there in person. You can't also replace being there in person. We are fortunate that we have very good nursing staff. So actually none of the staff generally are there for the actual study. So that's why I guess I'm maybe harping so much on, I really rely on them putting what they're seeing there because I'm not there in person. That may be different for other locations, for other institutions. Are you there? Are you guys there in person during your studies, or do you have a nursing capabilities that actually do it for you?
At my center, the nurse does the study, and then we get the report from them.
So very similar to what we're doing. So do they generally kind of give you the clinical, correlation of what's being asked of the patient, what they're noticing kind of on top like this, or maybe even handwriting?
No, not really. We've not been getting this.
It might be helpful. It might be helpful because again, knowing that this is not maybe a volitional void, like the patient isn't trying to void here, then you might misinterpret this as thinking that this is dysfunctional voiding or DSD if you have a patient with a spinal cord abnormality versus that this could be a normal guarding reflex. I have another example of that here in a second, but this is just showing that there's not really much activity going on versus here. So, they're having all this overactivity until, the patient's not specifically asking and they're even leaking, but their sphincter is firing probably to try and prevent that leakage and really just to respond to this overactivity. So I wouldn't necessarily call this DSD or dysfunctional voiding. I would say this is guarding up until I know that they are volitionally trying to void. This is an example where the lead got wet. And so it looks like you have all this activity. It's the lead is malfunctioning. So that's part of the problem again with having, a patch versus a needle. So kind of again asking, what can a VCUG add to the urodynamics? We've talked a little bit about this previously, but really it's helping you look at the kind of the health of the bladder, and it's going to allow you to look for reflux. It's going to allow you to look at the outlet. So, these are some normal appearing, nice smooth walled bladders. Whereas, this, if I didn't know that a child had a spinal cord abnormality, I was maybe doing video urodynamics for incontinence, refractory to, medications and things like that. And then I saw this on their video, let alone looking at, what their actual cystometry and uroflow look like, I would be very concerned and probably check their spine to make sure I'm not missing, a tethered cord or some sort of occult spinal abnormality. This is an example, again, sort of knowing where they are in the study. Is this them trying to void, or is this still during filling? Because this is concerning for, is their bladder neck kind of incompetent? Is it open? And then here, this is just sort of multiple things at once. So you have, an abnormal trabeculated bladder, and you actually have reflux probably into the seminiferous seminal vesicles and an open bladder neck. So you can get just sort of interesting information. Maybe this patient has recurrent epididymitis. And so now I'm like, oh, well, now I sort of see some of the issues going on and what, the anatomy is, what's happening when he voids. Okay, talking about pressure flow studies. So you have your voiding cystometry, but then that doesn't really tell you too much about what's happening in micturition. You can actually get, this portion of the study to look at what is the pressure during voiding and what does the flow of the urine look like. Again, it can tell you also information of what is the detrusor doing during voiding. So here, you see that during voiding, there's actual generation of pressure, whereas in this acontractile bladder, they aren't able. If I told you, towards the end that they were asked and given permission to void and they're trying to void, but they can't because there's lack of any sort of activity in their bladder. So they actually have an acontractile bladder. You can only tell that with though a cystometry with that basically that catheter in the bladder. So if you're just purely looking at pressure flow studies, you won't be able to tell that. You need the catheter in the bladder to actually measure the pressure in the bladder. You can also evaluate urethral pressures during the flow, but we hardly ever use that in the pediatric population. So I'm not really going to talk much about that. So looking at, again, during voiding, how do you capture and what are you capturing during the voiding phase? It's called uroflowmetry, and these are the endpoints. So if we walk through some of these, so this is what a uroflow looks like. It's a non-invasive way, so you don't need a catheter at this point. You have sort of a special toilet that is connected with, this actually is sort of what goes underneath this toilet that they pee into sort of, usually you have a container that will collect the urine, and it's measuring the weight and calculating and understanding the flow and the pressure. Actually, there's no pressure, sorry, there's no pressure component, it's just the flow. And it's connected to this computer that will generate a tracing that we'll look at in a second. So this can be, because it's non-invasive, one of the first lines of evaluation on a patient, and it will tell you something about their flow, what their post-void residual is, and also EMG activity, because you are placing EMG patches. But it does not, because there are no catheters involved, there does not measure pressure, and it does not measure compliance. You can do the flow at the end of your cystometry. You can either leave the catheter, ideally if they can pee through around the catheter, leave the catheter in, so you could get some pressure about what was happening in the bladder, as I showed you in the slide before, but you don't necessarily need that. And oftentimes our patients have issues urinating around the catheter, so you actually have to remove the catheter, and then we really just get this uroflow at the end. If you're doing an isolated uroflow, some considerations: it should be a private bathroom so that they're trying to recreate what they do at home, and they don't sort of, aren't tense and aren't sort of uptight, but being, watched. You want to make sure that the amount in their bladder to get a good reading, you want to make sure that they are voiding greater than 50% of their estimated bladder capacity. So we usually check a little bladder ultrasound to check volume before initiating the uroflow, and if they don't have enough in their bladder, we encourage them to drink. When looking at sort of a significant post-void residual, it depends a little bit on their age. So if they're less than 6, up to 10% of their bladder capacity is okay, but anything more, you start to worry. And you can also maybe just kind of make a cutoff of 20 milliliters. And then if it's greater than 7, there's even a smaller percent of their bladder capacity that we want left. And really, you should probably get 3 uroflows to make them representative. We tend to just do 2. So these are some of the images that you may see. This is actually a relatively normal, although this isn't like a completely nice bell-shaped curve, but this is a pretty normal image. So this top signal is actually the EMG pads on the perineum. This is actually some EMG pads that we happen to put on the abdomen, just seeing, looking for abdominal straining or abdominal voiding. But you see when they're basically initiating voiding, you see a nice quiet EMG activity. And again, you want this to be a nice sort of bell-shaped curve of, over time, what is the velocity of the urine. This is abnormal. So again, if we look here at the EMG activity and they're trying to void, you're seeing EMG activity with voiding in sort of a staccato type picture that would suggest, especially with their EMG activity during voiding, either dysfunctional voiding if they don't have a neurologic lesion, or sphincter dyssynergia, DSD, if they have a neurologic lesion. And here, again, this is a not normal image. You see that they're trying to void because there's some activity, and I didn't mention, this is the volume that's being collected in the basin at the in that on top of that base of that weight that I showed you in looking at the equipment. But this is showing that there is a volume that's being captured. So you know that they've started to void, but you really see their velocity is not, there's not much there. You see sort of this EMG activity. What this doesn't tell you is this an issue with an acontractile bladder? Because again, I don't have a catheter in the bladder to be reading the cystometry to know, is the bladder actually trying to squeeze and maybe it's hitting this sort of fixed sphincter, and so I get a horrible flow? Or is it because maybe the bladder is just acontractile and it's just sort of sitting there, and so they, while there's not a ton of Valsalva activity that I can see, I mean, that's why there's maybe they normally would void more by a Crede and sort of increasing their abdominal pressure. And that's why we see nothing really, no sort of flow and very small amounts of volume of fluid coming out. So some takeaway messages. We know that urodynamics is an important tool to help determine the safety of the bladder and also give us some of insight into, how a patient is presenting clinically. Video portions can help assess the anatomy of the bladder neck, and even the urethra. The uroflow that's added at the end, again, it can just be the end part of your urodynamics. It should be actually an important piece of the urodynamics, but you also can do it as an isolated study. It's less invasive, but it can tell you information regarding the flow of urine and the contribution of the pelvic floor to potentially what's happening. You see their post-void residual, see how well they're emptying. You do want to be careful because sometimes the clinical picture and what you're seeing don't correlate. You do have to remember that this study is a study. It's an artificial environment. Our patients, it's very hard for us, particularly in the pediatrics, to do standing urodynamics. Catheters fall out, things like that. So you have to remember that you also are oftentimes having the patient supine or reclined. And so you may not be adequately reproducing what's happening in their daily life when they experience maybe their leakage, because they aren't sort of, trying to perform activities, or they aren't standing, they aren't walking around. So sometimes you can be fooled as to, you can have a really pretty normal study, and maybe it is normal, but you also, again, you just always have to remember the clinical picture and treat that as well. So I believe I might have gone a little bit quickly, so I'm happy to go back and review some, topics, and even, go back through some tracings. I just wanted to make sure that I didn't run over, but though that's sort of what I thought were some of the important pieces of, understanding urodynamics. I want to thank you for your attention. I'm always available if you ever want to reach out to me. This is my email with questions. And then obviously I'll take questions now. So I guess I'll ask, what is your typical patient that you get urodynamics on? Or who are they? Are they worrying about incontinence? Are they following patients with known spinal cord injuries or abnormalities? Is it trying to diagnose those patients?
Yes. But for me, I find a lot of the patients who have obstructive lower urinary tract symptoms, but when you do not find a stricture or they are younger, those are the ones I'm most puzzled about.
So actually, interesting question about that. So do you also force, for example, knowing that they maybe have, significant BPH and you're getting ready to TURP them, would you do urodynamics to also assess if their bladder function has deteriorated due to their, lower urinary tract obstruction? Do you use it at all to help counsel or inform what the patient may experience after surgery? Or do you wait until you do the surgery, see if now they have, because maybe they've been voiding, they've really kind of blown out their bladder, and they have a really acontractile bladder, they're really generating anything by just sort of valsalving, abdominal voiding. Do you wait until afterwards to look and see what symptoms they may have? Because maybe they still will be in some element of retention after, even though they're anatomically unobstructed, but if they are functionally not, don't have a functional detrusor response, they may act very similar. Do you do any of that for that reason?
For that reason, not routinely, because the urodynamic studies add quite a lot of significant costs to the patient. However, routinely we do uroflowmetry. We rely on average flow rate and maximum flow rate to see who will potentially benefit most from TURP.
Sure. No, that makes a ton of sense. So do you have more readily accessible uroflowmetry versus cystometry?
Yes. Cystometry is not easily accessible for cost, but uroflowmetry is routine every day. Many patients go through it before surgery and after surgery.
Sure, to help document and kind of fill that obstructive, evaluate that obstructive element. Sure, no, that makes a ton of sense. Yeah, but I think, to that point with then who you reserve the kind of, more expensive testing, more invasive testing, I think absolutely, so maybe you've ruled out that there's not a stricture, based on age, you wouldn't expect them to have BPH, but they're having obstructive type symptoms or, incontinence or something like that. It can be a great tool to try and understand what's happening. And sometimes it's just reassurance. I mean, obviously in pediatrics, we get so nervous about just protecting the upper tracts because, I mean, sometimes incontinence when they're pediatric, may not be so important because maybe they still would be incontinent anyway with toilet training, if they're still quite young. But it's sort of reassuring yourself, like in, a spina bifida patient or a patient, where you just have concerns maybe on an ultrasound or they have really refractory incontinence, that something not more kind of concerning is happening.
Yeah, I see your point. Now I have a couple of questions I'll ask.
Yeah, please.
I'll encourage the other attendees. If you have a question, you can use the hand up sign. You can raise your hand. And, but for me to start with the TRUSA underactivity or a contractile bladder, apart from self-catheterization, do you see any new treatments to that?
Yeah, that's tough. I mean, I would say I don't think there are really oral medications that are helpful. What we do have access to are some neurostimulation opportunities, one being a transcutaneous electrical neurostimulation, so TENS, which is an external, you can try and use patches that are connected to the transducer that initiates the electrical activity, or sacral nerve stimulation, which is, surgically implanted. But you're right. I mean, for an acontractile bladder, it's really pretty difficult. I mean, I'll maybe sometimes also sort of talk about credating or some of, if there's some element of abdominal voiding that they can do. But yeah, short of, CIC, if they really want to get off of CIC, we'll sometimes offer the electrical stimulation in one form or the other, but it's a difficult problem because you're right, they're not great. They're otherwise, I mean, there really aren't, you can try things like, is it imipramine that maybe has some bladder, function without, having, and then also some relaxation of the outlet, but I've never used it for that indication. I think, worrying more about some of the side effects from that medication, I either really encourage them to just stay with CIC or again, consider neurostimulation. Do you have access to neurostimulation?
No, that one, no. I don't know any center being in Uganda.
Yeah, I wouldn't, I mean, and I would say it's, it is accessible here, but still even I wouldn't say that is a super common way of addressing it.
Okay, my second question, I would like you to review the slide which compared spina bifida and how the TRUSA and the sphincters respond. It was one of the early slides. I want to understand it better. There is a sacral injury, suprasacral injury, and then spina bifida in a table. There was a table.
I think I know what you're talking about. Sorry, it's a little bit slow. There we go. This one, right?
Yes, that one.
Yeah, so these are just sort of the generalizations of looking at the different lesions. So if they have spina bifida, typically, well, that's the problem. Spina bifida, it can be either overactive or underactive for their detrusor activity. Typically, the internal sphincter is sort of open and the external sphincter is fixed. That's why a lot of times spina bifida patients, if they do need surgery, they need a bladder neck procedure as well, which then you would, create like a catheterizable channel. For a suprasacral spinal cord injury, you usually see overactivity with dysenergy of the external sphincter, although the internal sphincter can be synergic. Whereas if you have, a sacral spinal cord injury, typically they contract all bladder. And their internal sphincter can be, competent, but it can also just be open, and they tend to have a fixed external sphincter. But it's not always so, it's not always cut and dry, but that's where you'll see like the patients after, like adult patients, maybe after an APR of their bowel that go into, because they've been damaged to their, the sacral nerve roots or something from their surgical dissection, that they go into retention.
Okay, I get that. There is another slide which showed it was a CUG showing reflux into the seminal vesicles.
Yeah.
Yeah, what pathology do you think is going on because that?
Yeah, it's a great question. So I probably would be concerned for DSD, that they are actually hitting a fixed, or that they have a fixed sphincter mechanism. Because there's some reason that there's almost increased pressure. So I would almost think that they have a fix, or, kind of, they aren't relaxing their external sphincter here, that you actually see this reflux, because again, it's sort of a pressure phenomenon.
Oh, okay. My last question. Yeah, it makes sense. It's a pressure problem. There is a backup. The last part about your urofrometry, you said sometimes you do it 2 or 3 times. How you fill the bladder by catheter, or because it could be really time consuming if you want the patient to drink and fill up?
You're absolutely right. Usually it'd probably be like separate visits.
Oh.
But if, I'm really altering, you're right, it's not always practical. It's not always practical, but to sort of, I think, to be as thorough as possible, to base something on a single uroflow, you may want to try and repeat it at some point.
Okay, thank you very much. Those are my questions. I'll invite Dr. Katie or any of the other people to really use the opportunity.
And I do believe that we're recording these, so I think that they can be reviewed at any point in time, or you can share them. Is that right, Katie?
Yes, we'll record the lecture. It's recording now, and we'll post it online. But do you think you can send me the slides as well?
Yeah, for sure.
Yeah, and thank you so much for this lecture. It's been great.
Yeah, thank you guys for your participation. Is there anything else that anything that I can answer? Otherwise, again, I'll put my email up. I'm happy to have you reach out to me if I understand sometimes you might not think of it right away, and if it comes to you later, or you have like a patient that you want sort of second thoughts on, or urodynamics you want second thoughts on. Well, again, thank you so much. Thanks, Katie, for setting this up, and please feel free to reach out.
Yeah, thank you so much, Christina, and thank you so much for organizing this, Dr. Kigongo.
Thank you, Dr. Katie, too. Thank you, Dr. Christina, once again.
Yeah, of course. Hopefully see you, hopefully, stay safe, and maybe sometime I can come to Uganda and meet you in person.
Sure, yeah, we'll be waiting.
Take care.
Bye.
Bye.